Hi, Dr. Gomes Johnson, a consultant nephrologist, a visitor in St. George's Hospital. Kindly, he will talk to us today about managing patients with cardio-kidney metabolic perspective and changing in their creatine clearance with medication. Thank you very much.
Well, thank you for the invitation. I would like to start that for us the best way to assess the eGFR is with the creatinine, obviously, but also with the cystatin C, and that's because heart failure patients, elder and frail patients, they maybe can overestimate the eGFR if we only use the creatinine. Okay, so after that, when obviously if we have an eGFR above 60, we can use basically every of the four pillars for this kind of pathology. However, what I would say is that as the eGFR declines, I would first ask the patient about other causes of this, for example, diarrhea, nausea, maybe NSAIDs or another medication that has not been prescribed by our medical team. And after being sure that the patient hasn't taken any of that medication and hasn't gone any extra renal losses, what I would say is that when you have a decline in the eGFR for 50% of the baseline, you may have to reduce the doses, most of the RAS inhibition, like the ACE inhibitors, ARBs, and MRAs, by half of the dose that they were taking it, and reassess after 2 to 4 weeks. If the eGFR drops 100%, it means like it doubles the baseline. I would definitely say withhold the medications for 2 to 4 weeks and then reassess again. And maybe my last piece of advice would be that if the eGFR is stable and you are only struggling with potassium, we now have new tools, new medications like the binders that you could give them to the patient in order to achieve an adequate dose without withhold the medications.